Depression is a word obviously in the English language, and it's used in many different meanings. So we talk about depression in the weather front, we talk about depression in the stock market, and people talk about their mood being depressed. And of course, your mood being depressed in and of itself is not necessarily an illness. What we are really talking about here is clinical depression or major depressive disorder. And this is something which has a number of characteristic symptoms, usually low mood or something we call anhedonia, which is a lack of pleasure and enjoyment in all things. One of those two is necessary. And also a range of other symptoms that affect things like attention and concentration, which is impaired, appetite, which is altered, weight, which is altered, sleep, which is very often disturbed, and so on and so forth. And those have got to go on for about 2 weeks at least before you can say that someone has a major depressive episode. A common confusion is thinking that major depressive episodes only occur in major depressive disorder. They can actually occur in other psychiatric disorders, particularly bipolar disorder, where you get bipolar depression. The big difference, of course, between bipolar disorder and major depressive disorder is that people with bipolar disorder at other times may have pathologically elevated mood, where they're hypomanic or manic. The question often arises as to whether the cutoff between normal moodiness of health, what Kraepelin called the well-founded moodiness of health, and depression, major depressive episodes, is a scientifically valid one. And I think there's pretty good evidence it is. So I think if you satisfy the 2-week criteria, the symptoms that I've said, generally it goes on for a lot longer than 2 weeks, then that's something which is worthy of treatment. The causes of depression are what we would call multifactorial. So the first thing to note is that depression is very common everywhere, but everywhere it's been studied that I'm aware of, there's a 2-to-1 incidence of women to men. So that means that women have twice as much depression as men. So typically there might be 4% of men at any one time suffering from depression, 8% of women, and something like that. Now this obviously could have multiple different effects. Some of this may be due to societal roles and greater pressure on women. It could be due to biological differences. It could be the fact that, for example, some of the sex hormones are more pro-depressant, and there is some evidence for that. And also it's perfectly possible that women are more likely to be upfront about being depressed, and it's easier to detect it, whereas men are less likely to be straightforward about admitting it. I think it's probably a mixture of all these different things. So that's an important factor. If we think about other causes, if you have a family history of depression or of bipolar disorder, your risk of depression is increased. We know that early life adversity is actually a big risk factor for depression in adult life. So we know that from a study, classical study done in Newcastle in the 1940s, where they followed people up into adulthood, if you had significant life adversity as rated by the health visitors, then your rate of depression was increased 6-fold. So early life stresses are actually very important. We know that immediate life stresses can precipitate an episode of depression. But remember, in a large number of cases, that's not so, and there's no obvious precipitant. So we shouldn't hang the diagnosis on whether there's a triggering precipitant stressor, because that may well not be there. There are, of course, other causes. Some medicines can cause depression. And of course, one of the big risk factors is recurrence of depression. So we know that if you look at a first episode of depression ever, 50% of people won't have a recurrence. If you look at the second episode, it goes up to about 70%. And for third episode depression, it's up to about 90%. So in a way, it's very important to remember that the more depression you have, the more of a risk factor there is for future episodes. Now, that's not a cause per se, but it's very important to be aware of. So when we consider how depression arises, we think of it as being multifactorial, which means potentially multiple different causes. And as I've said, you can be genetically loaded for depression. particularly if there's a history of depression in the family, major depression or bipolar depression, bipolar disorder. It's not commonly realized that the commonest psychiatric disorder in relatives of people with bipolar disorder is actually major depression. So these two disorders are very closely linked. Early life stress is, of course, something that makes people very vulnerable, and immediate life stressors are also something that triggers, in a number of people, but not all people, episodes of depression. And there's other things such as the effects of some medicines which can precipitate it. There's been much interest in the oral contraceptive pill, for example. The combined pill, which has got both estrogen and depression, in Denmark, which has very good record linkages, is associated with higher rates of depression. But interestingly, the single hormone pill, the progestogen pill, had even higher rates, suggesting that it's progesterone which might be more implicated. There's also an interesting parallel, to my mind at least, from the so-called male pill. This is giving men injections of progesterone to inhibit spermatogenesis, which works, but the commonest severe side effect in the men was depression. So obviously there are environmental effects which act on a stage which is set by genetics and early life experiences. And all of these are important to consider when we're trying to formulate a view of depression for each individual. I think stigma and prejudice are two sides of the same coin, and they're one of the big problems that we face with all mental health disorders, and they're one of the big barriers to appropriate recognition and to proper treatment and indeed recovery. I think this is magnified by depression because people who are suffering from a major depressive episode feel unworthy because of the illness, and of course the stigma and the prejudice would also tell them they're unworthy. So you're getting a bit of a double hit there, and it makes it very difficult to overcome. And this, I think, is one of the explanations why people with depression don't seek help. And of course, there's still some very regrettable attitudes towards mental ill health, sometimes in even healthcare professionals. I mean, one of the things that's striking is that people with severe mental health problems, including depression, actually tend on average to receive much poorer physical health care. So again, this is a double hit. Not only do you have a mental health problem, but the common physical health problems are less attended to. And indeed, this is a big explanation for the premature mortality, the people dying younger, which occurs with all the severe mental health groups, including things like schizophrenia, depression, and so on. And they die predominantly because of the common killers, things like heart disease and so on. So they're obviously not getting the level of care that the rest of the population is. The other thing that should be said is that we have this concept of comorbidity in psychiatry, where you can have, say, depression and you can have, say, a personality disorder. Personality disorders are certainly real phenomena, but with mood disorders, and particularly with depression, there's a tendency, in my view, for personality disorders to be overdiagnosed. Because someone is upset or has a labile mood or is sensitive to rejection, this does not necessarily mean that they have a personality disorder. This can be explained by the depression. So although we should be quite clear that you can have a comorbidity, so you can have depression and a personality disorder, in my view, this is overdiagnosed, and in our practice we very often see when the depression is treated, the so-called comorbid personality disorder disappears, and of course that means it wasn't a personality disorder at all. One of the great developments, one of the great beneficial things that I've seen in the past 20 or so years has been much more inclusion of people who've had lived experience and learning from that and reflecting on how that might improve practice and promote recovery. And I think there's been some early pioneers who've been really very brave with going ahead with that. I think there's still stigma and prejudice, and that makes disclosure like this very difficult at times, because there are still some difficult attitudes, I think. But nevertheless, we've seen in lots of areas of our society, from people's sexual preferences to lifestyle choices and so on, we were much more tolerant and accepting of alternatives. So hopefully we will see the same toleration and improved compassion, really, towards people with depression. It should be pointed out once again that this is even more difficult if you have depression, because very often people with depression feel unworthy, they feel as though they're an imposter, they feel as though this isn't a real illness like having a broken leg or something gives you a nasty rash or whatever. All of the evidence and all of the informed thinking says that's not so, but nevertheless it's very difficult for the person with depression to shake off. So I think we should encourage this, we should educate people, and we should try and support people with lived experience in helping us to help them better as much as we can.